think heart attacks and poor cardiac outcomes are the leading cause of death in this country.
Every fourth death that occurs in India today is because of heart attack or stroke. See, healthy lifestyle plays a very important role in prevention of heart disease. Complete distance from smoking.
Absolutely zero.
Zero. It makes whole LDL particle even more dangerous. So it's a modified LDL which is even more harmful. And Indians unfortunately have a higher compared to most of the communities in the world. I would just like to re-emphasize one point that we must start early.
Welcome to the OddsFitness podcast. Today we have Dr. Manish Bansal, who's the Senior Director at Medanta Hospital, which is one of the top hospitals in this country. He's the Senior Director of Clinical and Preventive Cardiology, and he's won numerous awards. In fact, since I'm into research, I myself am somebody who heavily practices researching on a daily basis. My formal education being in exercise and sports science, I go through a lot of research papers and everything, and I was very happy to see that you're one of the top 2% of researchers on a list from Stanford University. So, somebody who is in your position, the reason why I'm excited about this podcast is because not only does he have experience of practice, but also a lot of experience of a lot of research, and when I meet many practitioners, everybody has their own style and they go through their own personal style of research, and they have their own philosophy of understanding things. But the reason why this is so credible and this is so important is because Dr. Manish comes from a variety of experiences, and once somebody is exposed to so much information and data, I think information gathering is the critical component of decision making. So whatever he has to say, I definitely am going to follow when it comes to heart health. And welcome to the OddsFitness podcast.
Yeah. Thank you so much. Thank you for this invitation. I'm really excited about today's podcast, where I believe we'll be able to discuss many important things. And as you mentioned about my research experience, it definitely has shaped how I practice clinical cardiology in my daily life.
Right. So, Dr. Manish, first about you. How did you get into this field, and what inspired you to become a doctor?
Okay, so I actually belong to Jaipur and I am from a modest family, but I was very good in academics since my childhood. So always number one position type. And I, for me, the my favorite subject was mathematics,
Wow.
and the second favorite was physics. But at the same time, I saw this profession of medicine with a lot of, a sense of pride to be a part of that profession. And I saw that doctors, they had such great role in our overall well-being. They were so much respected in the society, and they, uh, so to say, had so much power actually. So that attracted me towards this profession. But as I said, my favorite subjects was maths and physics, not biology. So I wanted to become a doctor studying maths and physics. Unfortunately, that was not possible. So when I took up biology, initially it was a difficult phase for me,
Yeah.
to cope up with that subject. But eventually it everything settled, and then I continued my journey. So then I joined Maulana Azad Medical College for my MBBS,
Yeah.
which is one
A
of the
prestigious institute.
topmost institutes in India for that. Then I did my MD medicine from All India Institute of Medical Sciences,
Wow.
and then I did my DNB cardiology from a Scots Heart Institute in after finishing my MD.
Wow.
And then for a year I was in Australia, further uh, getting further getting exposed to newer fields of imaging, and I got a lot of exposure in research also.
Wow.
So that's how it's been.
Wow, amazing. And do you think your parents played a role in, supporting you, encouraging you, even if it's maths, it's, be an engineer or, be a doctor? Who helped shape that decision of yours?
No, they have been absolutely instrumental, no doubt about that. But and my decision to become a doctor was uh, it had a lot to do with my family, parents.
Right.
They were very supportive of this idea. They always wanted me to become a doctor.
Right.
Although in terms of subjects or teaching, I did studies on my own.
Right.
But yes, they were fully supportive of my decision right from the beginning, and they provided me all the support that I needed throughout this journey.
Wow. Amazing. So, when we talk about your time at college, whether it's Maulana Azad Medical College or All India Institute of Medical Science, do you think that experience there, then, what is it that made you decide that you want to go towards cardiology and you want to study the heart and blood vessels and,
So,
of course, all those things?
honestly speaking, the decision to become a cardiologist was clear to me even before I took up biology in
Wow.
11th standard.
Wow. That's
That's
people
the
having
yeah.
vision.
So somehow this field clicked with me, and I found heart to be very dynamic and uh, very appealing organ profession, whatever you may call it.
Right.
So I took up biology only to become a cardiologist.
Right.
Okay.
Okay.
Then I did MBBS. Then I chose medicine, even though I had options to choose some other more popular specialties like radio diagnosis,
Right.
And orthopedics, which were at the top at that time. I chose medicine because I wanted to become a cardiologist.
Right.
So this decision had been there for many years.
Wow.
From my school time.
Amazing. That's like,
Mm.
dream. You have a dream, you pursue it,
Yeah.
and, laser focus vision and just going at it. I also hear that you were on Dr. Trihan's team since the very early years of your career. So, could you give us a little key insights on how working with him and maybe working with his team is distinctly different with working maybe elsewhere if you have, doctors that you converse with? Because as we all know, he's one of the most, how do you say, methodical, disciplined, and I think he has a vision for everything. So, could you shed light on that?
So again, working with him has been one of the most fulfilling experiences for me. And after finishing my MD, I joined Escorts Heart Institute, which was the institute built and managed by Dr. Trehan
Right.
at that time. And I've been with him for the last 25 years since then. So I've not moved to any other place.
Right.
That itself tells everyone that how much engaged or fulfilling I found this experience. The main difference working under Dr. Trehan and I believe working at any other hospital would be that here we have the mix of uh, best combination of a private setup
Right.
and a government setup.
Wow.
We've got all the amenities, latest technologies, and at the same time, no commercial pressures at all.
Right.
So we are all salaried. I don't have to worry about how many patients I'm seeing, how much revenue I'm generating. Never this thing arises in
Wow.
for last 25 years. This has never been a topic of discussion for us. We have to just do a good quality work, and then he has the ability to get all the leading people, experts under one roof and have them work as a team. It makes working very, very fulfilling. So not only in cardiology, I have my colleagues who are doing very well in their respective fields, but other specialists also with whom I interact, they are all leading in their respective fields. So then the patient care becomes very good, and interactions become very good. So the whole experience becomes very good.
Right.
And
Because,
sense commercial pressures.
I was reading in this book, it's called Beyond Entrepreneurship.
Hmm.
I think I read it there. I could be wrong, but most likely it was there. And, the whole idea of having the highest talent density, having the best people that are ever there, that just compounds the effectiveness of an entire group.
Yeah.
And I think what you're telling me is something that I resonate with there, because, having the best talent together will always make sure that the group is elevated.
Yes, and he is an absolute visionary. Just no comparisons actually.
Right, right. No, I've heard that before as well.
Yeah.
I'm Dr. Jasjeet Wasir, and
He is an amazing.
he's an inspiration for me as well. So Amazing. So more about, let's say, cardiology now. Um, I think heart attacks and poor cardiac outcomes are the leading cause of death
Yeah.
in this country.
Yeah.
What would you do as, let's say, a public health expert or somebody, who has got policy in his hands, like you said, power? What would you do for this country, or maybe, this city in general, that can significantly reduce that?
Okay. See, it is true that cardiovascular disease, or in simple terms, heart attacks and strokes, are the leading cause of death.
Yeah.
And for our viewers, I would like to mention that every fourth death that occurs in India today is because of heart attack or stroke. So every fourth person. And this includes all types of deaths: cancers, accidents, COVID, infection, other infection, whatever we may think of. Every fourth person who's dying is dying because of heart attack. And unfortunately, in India, this proportion is increasing day by day, and heart disease is occurring at a younger and younger age.
Yeah.
Compared to Western countries, we develop heart disease roughly 10 years earlier, 5 to 10 years earlier. So this is a big problem. So if I were the policymaker, I think first thing is to make everyone aware about this. This should be part of the curriculum. Right from the school, children should be taught that this is a very important issue that we need to address. And second, we need to make everyone aware that it is a disease which can be prevented.
Right.
Unlike cancers, where uh, we may not be able to do much to prevent it, here it is absolutely preventable.
Right.
So if we know how to prevent it, and if we know the importance of prevention,
Right.
then I think we can reduce the burden. And third important point related to this is that earlier we start, whatever we may do, earlier we start, more dividends we get.
Correct.
So it's very important. We need to understand that it is a big issue, it can be prevented, and early action will lead to much more benefit.
Right. Right.
Hmm.
So when you say early action, if I were to give 5 key takeaways just on one hand, so that it's digestible for a person, what would that be?
Okay, so uh, see, healthy lifestyle plays a very, very important role in prevention of heart disease. So, healthy eating,
Okay.
regular exercise,
Okay.
complete uh, distance from smoking.
Absolutely zero.
Absolutely zero.
So when you say smoking, is it nicotine or is it smoking?
Nicotine in pure form is not that harmful.
Okay.
In fact, we use nicotine in different forms to help quit smoking, like nicotine chewing gums
Right.
and other preparations.
Right.
But in smoking form, any form of smoking is really harmful.
Right. Right. So no smoking, healthy eating, exercise.
Exercise. Then fourth, I would say, is that it's extremely important for us to assess our own risk of developing heart disease, which could be because of genetic reasons, like parents having early heart disease or faulty lifestyle. And then fifth is that if the risk is high, then in addition to lifestyle measures, at an appropriate time, we also need to look at how we can reduce LDL cholesterol, which is the key reason responsible for these plaques building up and heart attacks and strokes occurring. So healthy lifestyle is extremely important, but in many individuals who are at a high risk, we have to go beyond healthy lifestyle also, so that we need to understand when and how.
Understood. So maybe detailed nuances can also help.
Yeah.
So when you're saying LDL cholesterol,
Yeah.
would it mean just LDL, or are there like ApoB particles or other kind of lipids that matter, triglycerides, LP little a? Do these individually matter, or is it just LDL that mostly matters?
Okay. Yeah, it's a very important question. See, cholesterol circulates in our bloodstream because cholesterol is required for normal body function.
Right.
And there's no confusion about it. Cholesterol is very important for life.
Yes.
But as long as it remains in bloodstream, there's no problem in it. When it starts getting deposited into the walls of the arteries, then problem arises. Now, cholesterol circulates in blood in different packets,
Right.
because it cannot float independently. So it
Right.
has to be packaged in the form of packets and then distributed to various organs. So one such packet is LDL.
Right.
So LDL is a particle which contains cholesterol also, some other elements like triglycerides, and a protein called apolipoprotein B, ApoB.
Yeah.
Now, then it undergoes modifications as it circulates. It gets converted to other ApoB particles. Eventually, it is taken up by liver. Now, in this process, it can also get enter into the vessel wall and can get deposited.
Right.
So, LDL particle and all its successors, which
Right.
also contain ApoB, are harmful, because when they get deposited in the artery wall, they cause plaque buildup and blockages. So, not just LDL, but all ApoB particles are harmful. But in circulation, cholesterol in the form of ApoB particles is carried 90% in the form of LDL. So
Right.
LDL becomes the main molecule for us for simple messaging, for easy interaction with the patients, communication. We use LDL as the main focus of our discussion. But as you mentioned, ApoB is more important.
Right.
However, for the discussion, I will still focus on LDL only because it's easy to understand.
Got it. And what about LPA?
Yeah. Okay. So LPA is a modified form of LDL. So here there is another apoprotein that is known as apolipoprotein A. It makes whole LDL particle even more dangerous. It has greater propensity to get deposited. So it's a modified LDL which is even more harmful. And Indians unfortunately have a higher proportion of LPA as compared to most of the communities in the world.
Right. Right. And those could be genetic factors
Yeah.
because of which Indians are getting
Yes,
more
yes.
attacks.
LPA, in fact, is determined solely by genetics, and in one's lifetime, LPA level remains same
Right.
unless you take specific medication which can specifically lower it. Lifestyle changes don't affect LPA. Any other thing will not affect LPA. If you measure LPA at 20 years, it's going to be same at 50 years of age because it's genetically determined.
Right. Right. So I don't know. I maybe that there was a variance in the sample that was taken or whatever it is. But like I was telling you when we were discussing earlier, there was some significant lifestyle changes that I made, and I've read everywhere consistently that
Yeah.
LP little a doesn't change, LP little a doesn't change. I'm sure it's a variance in the sample that was collected, because now that I'm thinking about it, of course, those are the contributing factors that can do that. But once I did that, my LDL also, like I told you, went down significantly
Yeah.
with lifestyle, and there was a marginal decrease, maybe like 7 to 8% in my LP little a. So do you think that that would only be because of how maybe my sample was collected or how it was seen, or any of those errors contributed to it? Or is it possible that with some lifestyle modifications at all, that can be changed?
So, yeah, I remember you told me about your journey, and you told me how you could have significant reduction in LDL
Right.
through lifestyle measures. But by and large, LDL drops by roughly 15% with lifestyle modification. In your case, you had much more reduction, maybe because you are so informed, you are doing all the right things in combination. So, eating healthy, exercising, everything.
Right.
When we talk of studies which have looked at the effect of lifestyle measures on LDL, they are from real people, real life experiences. So there, one is not able to do all that you could be doing. So
Correct.
in real life practice, we see that hardly there is 15 to 20% reduction in LDL with lifestyle measures.
Right.
And therefore, when we want more LDL reduction, we have to go beyond lifestyle measures.
Right.
LPA reduction by 7 to 10% is understandable. That may happen
Right.
because although I mentioned that LPA level remains constant, but some degree of variability can be there,
Right.
and it can decrease with lifestyle measures also
Right. Right.
by a small margin though.
Right. Small margin, I'm sure, because I'm sure there would be some adaptations or enzymatic processes
Yeah.
that take place
Yeah.
which can maybe do that. So, at Odds Fitness, we're always advocating that, if you exercise, eat right, and do all the right things,
Yeah.
people say that, he did all the exercise correctly, but still he died of a heart attack.
Mm.
I'm like, it's like I give you one dice and I say roll a 6.
Yeah.
And then I give you 6 dice and I say roll a 6.
Mm.
What's easier?
Mm.
So you just reduce or stratify the risk significantly. It's not that you can completely eliminate,
Eliminate it, yes.
right? Even with, I'm saying people who take statins or take lipid lowering medications, they also can have heart attacks.
Yes, yes.
Right. But our idea is to, make sure that awareness is there and people are using the right tools to, take early measures in order to reduce the probability of a poor outcome happening.
Yeah. No, that's very true. Although I mentioned that lifestyle measure alone will not reduce LDL by a huge margin, but so before I answer this question, I need to also explain another thing, that LDL cholesterol deposition does not depend only on LDL level.
Right.
That's a very, very important thing that we need to understand.
Yes.
It depends on a combination of the health of the blood vessels and LDL level.
Right.
And my favorite example here is you take an example of walls. We have homes, we have walls which are painted, we have plaster. If the quality of plaster and paint is very good,
Yes.
then whatever amount of rain it may get exposed to, seepage will not occur.
Right.
If the plaster is not of good quality, then seepage will occur even with first rain.
Right.
Okay. Similarly, in our arteries, if the arteries are healthy,
Right.
then they will not allow LDL to get deposited,
Right.
even if LDL level is high.
Right.
On the other hand, if the arteries are not healthy, then LDL will get deposited even if LDL level is not high.
Correct.
So therefore, people who have diabetes, who smoke, who lead a sedentary life, who are obese, who have hypertension or have a lot of stress, they can develop blockages and a heart attack even though their LDL is not high. Okay?
Right.
So here comes the importance of lifestyle modification. It will reduce LDL by some margin, but it will make arteries healthy by a huge margin.
Right.
So lifestyle measure will take care of blood pressure, will reduce chance of developing diabetes. It will reduce obesity, inflammation, vascular injury. So arteries become healthy.
Right.
And therefore, lifestyle measures are absolutely important. There is no substitute for that.
Right. So, Doctor, coming back to medication.
Yeah.
So, there are all these new drugs that are coming out. And, there's this PCSK9 inhibitor, inclisiran, like you said. Do you think that in the future, these drugs will replace the standard drugs that are being used right now? Or, the line of treatment would always remain, first statins, bempedoic acid, and then maybe if, you have absolutely stubborn LDL cholesterol, only then one must.
So see, so far we have huge data supporting beneficial effects of statin. Almost 4 decades of experience is there. So statins remain the number one drug.
It would be the cardiac equivalent of metformin, because
Yeah, much more than that.
much more than that.
Much more than that.
Right.
Okay. It's extremely beneficial.
Right.
And the side effects are negligible, contrary to what people might think.
Right.
The only significant side effect is body aches,
Right.
muscle cramps, which may occur in up to 10% individuals.
Right.
90% won't have any problem.
Right.
More serious side effects are very, very rare, and there is no reason to be worried about those side effects. People worry about dementia, but a lot of recent studies have shown that statins actually reduce the risk of dementia. So there are now plans to do studies where statins will be tried to prevent dementia rather than causing it. Okay.
Do you think it's because it improves blood vessel health?
Absolutely.
Right.
Yeah. Okay, because bad vascular health or bad vessels is a reason for dementia also. So because of that reason, statins reduce the risk of dementia. So statins remain the most important drug. Now there are newer drugs like bempedoic acid and ezetimibe. So they have less evidence, although we use them when we are not able to reduce LDL sufficiently with statin alone because they are oral, less expensive. Then we've got some injectable drugs like PCSK9 inhibitor known as evolocumab, which is available in India, and a PCSK9 synthesis inhibitor, inclisiran, which is becoming very popular because it is an injection that has to be given once in 6 months. So very easy to take.
Right.
And inclisiran is very powerful. It can reduce LDL by almost 50 to 55%.
Right.
And so far, virtually no side effects except the injection site reaction.
Right.
So once you inject, there may be some reaction for 3-4 days. That's it. We have evidence of roughly 8-9 years so far. We don't have 30-40 years experience as we have with statins, but in 8-9 years there is no risk of no concern about no safety signals at all.
Right.
But the main problem with inclisiran is that we don't have the same kind of outcome data as we have with statins. So
Right.
we know that it reduces LDL. We have early evidence showing that it reduces risk of heart attacks.
Right.
But large studies showing that are currently underway.
Right.
In 2 years' time, we will have those results also.
Right.
So far, statins remain the first line because of the evidence and cost also. Statin is much less expensive compared to inclisiran.
Right.
In times to come, when we have evidence showing efficacy of inclisiran in reducing heart attacks, not just LDL,
Yes.
and cost also comes down, then maybe the situation changes. We don't know. And it may become, it is a possibility that inclisiran becomes the first line
Right.
agent.
Right.
But for that to happen, two things have to happen. We have to have good evidence showing their
Outcomes.
efficacy and long-term safety and cost reduction also.
Right. Right. So I think that's one of the most interesting drugs on the market, because if that becomes the new statin with the right kind of knowledge and study around it, I think it reduces LDL to such a extent that heart attacks would be at least, if the contributing factor is only LDL. And like you said, there are many contributing factors, but if it's only LDL and if it reduces it that significantly, then I think heart disease would be history.
So there's one very important thing here
Right.
that we need to understand.
Yeah.
See, this cholesterol deposition starts early in life,
Yes.
in first decade, second decade itself. But it becomes manifest many years later, in fifth, sixth decade. In India, maybe a little earlier also. But around that 50, 55, that is when it becomes manifest. Now, the problem that we have today is that we are acting when it is already too late, at around 45, 50, or even later, when significant amount of cholesterol deposition has already occurred. Now, we cannot reverse that. We can reduce it. We can make some part of this quiet, but some other part will create problem.
Right.
If we start lowering LDL earlier in life, let's say in second decade, and we reduce LDL significantly, we can then actually eliminate heart attacks and strokes.
Correct.
So whether it is statin or inclisiran or any other drug, if we want to eliminate heart attacks, we have to start early.
The earlier the better.
Earlier is the better. And there are many studies which have shown the power of early LDL reduction. In fact, I was mentioning to you one study, last study, where individuals who had LDL 110,
Right.
110 milligram per deciliter,
Yeah.
their risk of having a heart attack was 80% less compared to individuals whose LDL was 130. So just 20 milligram lower LDL, but heart attack risk 80% less. Why? Because their LDL was low because of genetic reason, and because there was a genetic reason responsible for low LDL, so they had relatively lower LDL throughout their lives. So
Right.
their arteries are exposed to lower LDL since their childhood. So acting early is extremely important.
And do you think that if you go even lower, there is an incremental reduction?
Yes. There's no threshold below which there is no further benefit with LDL lowering. In studies with PCSK9 inhibitors, patients who achieved LDL less than 10, less than, they had the lowest risk of having a heart attack. So there is no bottom line for LDL lowering.
What would be the offset of having really low LDL?
Currently, there doesn't appear to be any actually.
Right.
In some individuals, there may be some side effects, as I mentioned, 40x, but they are not related to, they can occur at any level of
They might be
LDL.
because of
Statin,
statins,
yeah.
but just LDL
Just
reduction.
low LDL, so far, no credible signal to indicate any increased risk.
Credible, yes, because somewhere I read that LDL is protective against cancer or something like that. I could be wrong about it, but there was some um, random, I think, study that I saw, which was I didn't see exactly, but I thought I'll just ask you.
So, see, so far we have uh, data for 10, 15 years with statins, and much longer when LDL is lowered naturally because of these genetic mutations, and there was no increased risk.
Yeah.
In fact, there are some communities in the world where, because of PCSK9 gene mutation, LDL level is very low,
Right.
less than 30,
Right.
right from the childhood.
Right.
They don't have any problem. They live much longer.
Right. Wow. That is very insightful. Very, very insightful. So, okay, now let's talk about, because we understood, what supplements can one take? These are the medications, the pharmacological interventions. What about maybe some natural things that maybe a person can take to reduce LDL or improve cardiac health?
Okay. So, in terms of eating, mm, good consumption of fruits, vegetables, nuts
Right.
is extremely important. Nuts are very, very helpful, like walnuts, almonds, pistachio.
Right.
They lower LDL.
Right.
They have so many other nutrients also. Then some other food items like flax seeds considered to be good,
Right.
and uh, uh, the routine things like uh, you know uh, proteins, yogurt, uh, and the omega-3 fatty acid rich fish.
Right.
So those are the things which are good.
Right.
So in terms of supplements, I would be mentioning mainly nuts and flax seeds.
Yeah, and if somebody is not able to have regular access to them, maybe they can take omega-3 or some kind of supplement which can, maybe, or does that not
Yeah.
make up for it?
So actually, omega-3 in terms of supplement does not lead to that much benefit, because if you are consuming it as a supplement, we need to have good quantity of omega-3,
Right.
which is not available in the supplements, most of them.
Right.
They provide only a small amount.
Right.
So natural sources, omega-3, mainly uh, certain kind of fishes,
Yes.
that is the best way to consume omega-3 fatty acids.
Right. Because it's a macronutrient, you need it in large
Yeah.
volumes. Right. And could you also shed light on, let's say somebody is taking a supplement, then they look at EPA, DHA, and all these things that are there. What should one look out for if they are considering,
Yeah.
if they're buying a supplement or something like that?
So actually, there are two things. One is the ratio, and second is the overall quantity. So
Right.
as I mentioned, the supplements that the studies which have shown benefit with omega-3 fatty acids have used EPA DHA combination in the quantity of 2 to 4 grams per day.
Right.
The supplements have hardly 300, 400 milligrams.
Right. Right.
So that becomes a problem.
So EPA and DHA 3 to 4 grams a day,
Yeah,
and we are taking nothing close to that.
nothing close to that.
Right.
Yeah.
So how should one have, because even nuts,
Predominantly EPA.
right?
Yeah.
So
not DHA.
so high EPA is
Required.
beneficial
Yeah.
for. So if EPA has to be high, and people don't have access to fish, people don't have access to that high volume of nuts, how should one go about it?
So in that case, getting enough omega-3 fatty acids in diet becomes a challenge. There, I would say the alternative option is to take care of other aspects of diet and exercise,
Right.
to compensate for the lack of omega-3 consumption.
Right. 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 Oh, that's very insightful. One very important thing, you said that the walls have to be nice.
Yes.
They have to
Yeah.
be good.
Yeah.
Indian diets are very, very poor in B12.
Yes.
And homocysteine levels, can be reflective of how your arterial health is. Could you shed light on that?
So I have a different take on homocysteine.
Okay.
Elevated homocysteine can lead to clot formation,
Right.
independent of vascular health,
Right.
because it is involved in the coagulation cascade, lead to clot formation. Clots can form in the arteries and veins both,
Right.
all types of blood vessels.
Right.
But lowering homocysteine through medications is not needed. It's not shown to be beneficial, except in those individuals where they have already had some events
Right.
and where homocysteine is elevated because of some genetic mutation.
Right.
The enzyme which codes for it, if there's defect in that, homocysteine level is elevated, significantly elevated, then only it matters. So, as a routine, we don't look at homocysteine as a vascular risk factor. We
Right.
don't chase it.
So even if it is elevated for someone,
Yeah. So suppose I do some testing and I find that homocysteine level is really elevated.
right.
Then obviously in that case I'll treat it. But let's say if the value upper limit of normal for lab is 15, the value is 20, 25, I'm not going to do anything for that.
So what can one do to improve or actually assess uh, how the vasculature and the health of the blood vessels are?
Yeah, I think this again is very, very important question and something that everyone should know about. You see, so we've been talking about risk of developing heart disease, cholesterol deposition, and at the same time, we also understand that many patients who have got risk factors for heart disease, they have diabetes or high blood pressure, but they don't develop a heart attack. On the other hand, there are others who don't seem to be having any visible side effect, a visible risk factor, and they end up with a heart attack. So, what translates these risk factors into heart attack? We don't know, currently understand that. We don't know what is the link between risk factors and actual disease. And therefore, just looking at the risk factors is not sufficient. If I say, if I look at my risk factors and measure cholesterol, blood sugar, blood pressure, and I calculate my risk, and the risk is 25% over next 10 years, then that means there's 75% chances that I will not have a heart problem.
Yeah.
Now, I don't know whether I'm going to be in those 75 individuals out of 100 or in 25 who are going to have a heart attack.
Right.
Therefore, it's very important that we move beyond the risk factors alone and we look at the vascular health directly. We see whether cholesterol deposition is already taking place or not. If it is taking place, then it does not matter whether I have risk factors or not. I am developing a disease.
Right.
On the other hand, if I have got multiple risk factors, but my arteries remain healthy for whatever reasons,
Right.
then I can be little less aggressive. Although I wouldn't say that if you have risk factors, don't worry about them. You need to take care of them, but the chances of developing a heart attack become less.
Right.
So there are now currently various tools that are available that allow us to assess vascular health. Two important tools out of all that are available are, one is CT calcium score.
Okay.
It is a CT scan based test in which a CT scan of the heart arteries is done. No dye is injected. Test takes only 1 minute. We just measure the amount of calcium which is there in the arteries. Now, calcium gets deposited only if there is cholesterol. So, by looking at calcium, we are actually getting an indirect evidence that cholesterol is there.
Right.
This is done because we cannot see cholesterol directly. Unless we inject a dye, we cannot see whether cholesterol is getting deposited or not.
Right.
But we can see calcium without a contrast.
Right.
So that's why we look at calcium score. And it is a very powerful test. If calcium score is 0, then the risk of having a heart attack in the next 10 years is extremely low. Although at a young age, the significance of 0 calcium becomes less robust,
Okay.
less meaningful, because at a young age you don't expect arteries to become calcified. But above 50 years of age, if calcium score is 0, then that is a very good sign.
Right.
So that is one test, very easy to do. The other is
it how much radiation or
okay, yeah. Radiation exposure is also very less,
Right.
equivalent to just 1 mammogram.
Right.
Very less radiation exposure. And as I mentioned, it takes hardly 1 minute of room time
Right.
to do calcium score estimation.
But let's say if there's somebody who doesn't want the radiation.
So the alternative option is to do ultrasound of the arteries which supply blood to brain and to legs.
Okay.
So known as carotid ultrasound and femoral ultrasound.
Yeah.
If we find any plaque there, here or here,
Right.
that means cholesterol deposition is happening.
Right.
And since all the arteries of the body are same throughout the body,
Yeah.
so if someone is having cholesterol deposition here, very high chances that he or she might be having the same thing in the heart arteries also.
Correct.
So
That's
that's the
where
alternative.
a lot of erectile dysfunction is also.
Yeah,
Because
exactly related to heart disease because the blood vessels are same.
correct. Wow. So that's very insightful. Do MRI scans play any role?
No,
No.
not at present.
Right.
For
Understood.
early detection, no.
Got it. So that would be a CT scan and an ultrasound of your carotid artery and your
Yes.
femoral artery.
Yes.
Wow.
Yes.
I think an ultrasound anybody should get done.
Yeah. But we need to remember that at a young age, not finding anything is not such a reassuring finding as it would be at an older age. Conversely, if you find something abnormal at a young age, then that is a very, very alarming sign.
Right. And is there no blood test through which we can assess that?
Blood
Vascular
test,
health, maybe.
so no, I mean, there are some tests like HSCRP. That is a test which can give us an idea about inflammation.
Inflammation.
And
yes.
we know that cholesterol deposition is a condition which is associated with inflammation. So there are many studies which have shown that HSCRP is predictive of vascular health and future risk of heart disease. But we don't know how accurate it is in Indian settings where infections are so rampant. So,
Because of high microbial overload, you're getting falling sick once or twice a year. It will
yes,
always
yes,
be
yes,
elevated.
correct.
Somebody started an exercise, got injured. Again, it
Yes,
can be elevated.
yes.
So
Poor oral hygiene
yes,
and many other conditions
very
which
interesting.
can lead to slight elevation of HSCRP. So we don't have data from India to show its value as a predictor of heart disease. But in Western countries, it is really a powerful predictor. Apart from that, we talked about lipid profile, FOB, we can measure that. Then there's some genetic tests also available now, like a test called polygenic score,
Right.
which assesses one's uh, tendency to have a vascular disease in future.
Right.
Now that's another thing which has become available in India. And the beauty of this test is that genetic risk remains same throughout the life. So
Right.
we can test that at any age, even a school going child, if we can do this and we can find out whether he is genetically predisposed to have a vascular disease later.
Right.
And if we find high polygenic score,
Right.
we can tell the parents of that child that please
Yeah.
take care of him.
Yeah.
Focus on healthy lifestyle, regular checks to keep him protected.
That's another thing that, if I was policymaker, I would definitely look at.
Yeah.
That have it all across the country. I don't know the cost associated with it, but I
So
would.
it's not that easily available currently.
Right.
With time, in times to come, it will become more widely available,
Yeah.
more affordable. So eventually, actually, we need to look at everything: clinical risk factors, genetics,
Inflammation.
early evidence of cholesterol deposition
Right.
to assess the overall risk.
Right. Wow. So, wrapping all this informative stuff up, what, would a doctor like you, who's now achieved so much, done so much, what future plans do you have? More research. What is it that you would, look forward to? What's the next leg up?
Uh, from this discussion, I believe it is very clear that I am passionate about atherosclerosis, heart attacks, strokes, prevention. Uh, Currently, unfortunately, we don't have good risk predictors available for Indians.
Yeah.
We have tools available for Western countries. So, going forward over next 10 years, I would like to be involved in research that helps identify how best we can predict vascular disease risk in Indians and what best therapies or remedial actions we can take to reduce this burden.
Right.
So that's what, in terms of profession, my goal would be.
Wow. That's amazing. And that's, because I personally am trying to answer that question. My dissertation, PhD, is going to be on, modifiable lifestyle factors and how they extrapolate to longevity or lifespan. And, while we are talking about it, the whole idea of having research and what are the control factors, how do you measure, is it self-report, is it not? Those are some things that we try and eliminate at odds, because we have this unique, you know, proprietary method of doing it. It's called quantified health and performance.
Okay.
And what we do is that throughout a person's journey, when they are exercising with OddsFitness, we log every single load of exercise or strain or whatever things that they have been exposed to, then sleep, then all the lifestyle factors. We have some self-report on nutrition, and then we also double down on it with the trainer asking the person whether they match or not. So creating high reliability of data. And then once we understand a person's journey over 6 months, we know exactly this is the problem that's occurring with you. In fact, very recently, I don't know if you know of Dr. Mohsin Bali. He is
heard his name, yeah.
Yes, very famous Padma Shri awardee cardiologist, and he called me yesterday. He said, "Asad yaar, तुमने तो कमाल कर दिया. तुमने मेरी metformin बंद करवा दी." मैं बोला, just as you have dedicated your life to studying medicine and disease, I'm at least trying to figure out what is it that this country lacks and what is it that we can give in a unique packaging to this country, because Delhi is not walkable. Delhi is high on pollution. What can be done here which is locally specific, which can help improve the quality of their lives? And he's stronger than before. I told him, I said, there is a GLUT4 receptor in your muscle. It will not need insulin. अपने आप glucose जाएगा muscle के अंदर, and you will not be, insulin insensitive. Diabetes ठीक हो जाएगी. Strength training is key. And he's like, okay. And he's a advocate of it. And I'm so happy that it's, shaping up and showing on people. So that's.
So I'm aware of the work that you and your team have been doing. I looked at your protocols. I interacted with your team also. And I know that you are doing an amazing work.
Thank you so much.
Unfortunately, in India, we don't have many experts who can give right advice about diet and exercise, particularly exercise.
Yes.
Diet still we can read on internet and we can get reasonably good information.
Yes.
But for exercise, there's a lot of confusing information available on internet and social media. So for a lay person, it becomes extremely difficult.
Yes.
Now, if I were to talk about my own thought process about it, till some time ago, we used to advise brisk walking, 30 minutes every day, 5 to 7 days a week. This has been the standard recommendation from our side. But then now we have also realized that no, this alone is not sufficient. Strength training is extremely important in combination with aerobic exercises. Only aerobic exercise alone are not going to do all the job. So that understanding is evolving amongst clinicians. And for lay public, obviously it's going to be even more difficult to get to the right information. So providing right information, guiding them through right process is extremely important. And I really compliment you for doing all this.
Thank you so much, doctor. Those are, very generous words, and it validates my, effort. So I'm going to go back home and we work even harder because आपने ऐसा बोला है. Somebody as esteemed as you.
No, I definitely compliment you for that.
Thank you so much. And I think with that, we'll conclude this podcast. And I'm very grateful for having Doctor here. And I'm looking forward to, more research and your personal journey, like you just said, in the Indian setting and all that.
Thank you so much. It was a very good experience for me also. I would just like to re-emphasize one point, which is extremely important, is that we must start early. The biggest mistake that we are committing is we are starting to act at age 45, 50, 55 when it's already too late. If we start early, we can get much greater benefit as compared to when we start late. I think that's the message that I would like to share with everyone.
Yes.
Thank you. Thank you for having me here.
Yes, absolutely.